Welcome, everyone, to the NMOSD Master Class brought to you by the Patient Health Alliance. The Patient Health Alliance is a source of information and education for NMOSD, neuromyelitis optica spectrum disease, and related conditions. The content of the following presentation is based entirely on published data or expert opinion. The PHA is not a clinical provider and does not offer diagnostic, therapeutic, or clinical care recommendations or advice on personal health. All patients and caregivers are advised to consult with their healthcare team for specific information. In today's NMOSD Master Class, our overarching goals are to provide a practical update of latest information on a specific topic. The classes are intended to illustrate key themes or clinical pearls. They're formatted to be inclusive of non-specialist audiences, and we leave time at the end for active Q&A to emphasize some key points. I'll be moderating today's session. My name is Dean Wingerchuk. I'm a neurologist and serve as chair of the Department of Neurology at the Mayo Clinic in Phoenix and Scottsdale, Arizona. I also serve as an advisor to the Patient Health Alliance. It's my great pleasure today to introduce our featured speaker, Dr. Elias Sotirchos. He is an associate professor of neurology, of course, a neurologist and neuroimmunologist, and he's the director of the NMOSD and MOGAD clinic, all at the Johns Hopkins School of Medicine in Baltimore. And today, he'll be discussing treatment of acute relapses. Elias, it's a pleasure to have you. Thank you. I'll turn it over to you.
Great. Thank you, Dean, for that kind introduction. It's a pleasure to be here and to give this talk. And the topic that I'm going to be discussing today is on treating acute relapses in NMOSD and MOGAD. And we're going to be discussing steroids, plasma exchange, and beyond, so other treatments that can potentially be used in acute relapses. I think the first question to answer when we're delving into this topic is, what is a relapse, also known as an attack? And the first thing I just wanted to clarify was kind of the nomenclature and terminology that we use here. So the word relapse can often be used interchangeably with the word attack. Some, however, may prefer to use the term relapse for a second, third, or fourth attack rather than the first attack that a patient experiences. So just want to be mindful of that so that we're all on the same page here, that when we're referring in this talk to relapse or attack, we're referring to any attack of neurological dysfunction in NMOSD and MOGAD. And so in order to define it a bit further, what we define as a relapse or attack is the onset of new or worsening focal neurological symptoms. They should persist in general for more than 24 hours, typically for much longer than that, with symptoms worsening over days to weeks, especially if rescue treatment is not given during that time. And very importantly, we want to make sure that these symptoms are attributable to new focal inflammation due to the underlying disease, NMO or MOG, since there can be other things that can potentially cause patients to have new or worsening symptoms. One example is what we call a quote unquote pseudo flare or pseudo relapse, where old symptoms can reemerge in the setting of an infection, fever, or other stress around the body. But also important to bear in mind that people with NMO or MOGAD are not immune to developing other conditions, things that can cause neurological issues such as strokes or other things that are not related to their underlying condition. And so it's important to make sure that we're truly establishing that these new symptoms are due to the underlying condition, NMO or MOG in this case. And I'd refer our audience to the NMOSD Master Class with Dr. Benjamin Greenberg previously that discussed the approach to adjudicating relapses, both in clinical trials, but also in clinical practice, and how exactly we approach this. Now, just as a kind of brief overview, I wanted to show this slide here that kind of shows what kind of mechanisms are at play when a new lesion or attack is developing in MOG-associated disease on the left-hand side of the slide, and NMOSD in the context of antibodies against aquaporin 4 on the right hand of the side. As we can see here, there are multiple kind of things going on. And so in summary, and to kind of keep this, I think, simple, we are seeing that there's an immune attack occurring on the brain or central nervous system or optic nerves or spinal cord, depending on the area that's involved. And this involves a variety of things going on, including antibodies, which we know are key in these diseases, and these characterize the disease themselves. So the anti-MOG antibodies and the anti-aquaporin 4 antibodies that can cross over and latch on to their targets within the central nervous system. Other important things that are at play are what's called the complement system, which is a system in the immune part, which is part of our immune system that can poke holes essentially in cells and can be activated by those antibodies after they penetrate. And that's especially kind of an important mechanism in neuromyelitis optica. In MOGAD, it's a little bit less clear what exactly the role is and how important it is or not. And then also there is inflammation due to immune cells that go into the central nervous system and can cause inflammation. So this includes lymphocytes shown here, and other kinds of white blood cells like eosinophils or neutrophils and other mechanisms that can be at play. And so collectively, all of these immunologic effects kind of are at play simultaneously. And so the way that we treat the attack is the goal essentially is to ameliorate this immune attack, calm down the inflammation, and prevent further damage and allow repair to occur. Now, critically, in NMOSD and MOGAD, disability accumulates through attacks. And this is in contrast to multiple sclerosis. So in MS, the majority of disability accumulation has been shown to actually occur due to what's called progression independently of relapse activity. So this is when patients experience kind of a slow, insidious worsening in between attacks, which is due to a variety of mechanisms that is kind of out of the scope of the current talk today. But overall, the literature and studies from NMO and MOGAD have shown fairly consistently that this phenomenon is exceedingly rare or even non-existent in these diseases, with really relapses and incomplete recovery from those relapses being the primary substrate of disability in these diseases. This is also consistent with not only clinical studies, but studies that look at using things like MRI in order to assess whether there is subclinical disease activity, so disease activity occurring without symptoms, such as new lesions developing on MRI without symptoms in a patient with NMO or MOGAD. And this has been shown pretty consistently across studies to be rather rare in NMO and MOG antibody disease. Now, in terms of the attack types that we see in NMO, the core characteristics are shown here. And as the name neuromyelitis optica implies, the most common ones are optic neuritis, so inflammation of the optic nerve leading to visual symptoms, and myelitis, which involves inflammation of the spinal cord leading to symptoms such as weakness, numbness, bowel and bladder dysfunction. But then critically, there are other sorts of attacks that can occur. One very characteristic type that occurs in neuromyelitis optica is area postrema syndrome, which is characterized by inflammation in a part of the brain that leads to intractable hiccups and nausea, vomiting, and may often actually be under-recognized as being related to NMO in patients who don't have other symptoms, with patients undergoing kind of extensive gastrointestinal workups, and only kind of later it being recognized to be due to NMO. But also other sorts of attacks can occur with brainstem involvement, which can lead to a variety of symptoms, including double vision, facial weakness, difficulty swallowing, even issues with respiratory failure and issues breathing, as well as involvement of what's called the diencephalon in the middle kind of part of the brain, which can lead to impairment in behavior. Sleep disturbances especially can occur with what's called narcolepsy, but also even less commonly, brain lesions may occur in neuromyelitis optica. In MOGAD, we have similar overall types of attacks, although there are a few distinctions. Aside from optic neuritis and myelitis, which are shared, acute disseminated encephalomyelitis is an attack that is rather unique to MOGAD compared to NMO and involves inflammation occurring in multiple locations across the central nervous system, and is associated with impairment in level of consciousness, what we call encephalopathy occurring, mainly occurring in children, but can also cause other manifestations, including brain lesions that can be either in one or multiple locations, brainstem deficits, and a inflammation of the cortex of the brain, which can often result in seizures and is termed cerebral cortical encephalitis. Now, recovery from attacks in NMOSD and MOGAD can vary and can also differ not only amongst the two diseases, but also between patients at the individual level. But overall, as I think most people will have heard in the audience, recovery from attacks in NMOSD, especially with aquaporin 4-HG seropositivity, can be a single attack can be quite devastating, unfortunately, sometimes resulting in severe and permanent disability. But that's not the rule, but it can vary quite a bit between individuals. But because of this, attacks of NMOSD, we're often much more aggressive with treatment. In MOGAD, while recovery is generally good and better than in NMOSD, it is important to still bear in mind that a substantial proportion of patients may experience residual disability even after a single attack. And this is especially true with spinal cord inflammation, where while motor and sensory recovery can be quite good, patients often can experience residual bowel and bladder dysfunction or sexual dysfunction as well. And especially recurrent attacks, especially in the same location, can lead to progressive accumulation of significant disability in MOG antibody disease. So we should bear in mind that while recovery is good, we still need to treat these attacks effectively and aggressively in order to ensure good recovery. And just to put this into contextualize this a bit more, in one kind of the largest studies studying disability in patients with MOGAD, after 2 years of follow-up in incident cases, a significant proportion, about half, had some degree of permanent disability, including a significant proportion with bladder or bowel dysfunction, sexual dysfunction, visual disability, and even limited mobility, although that was in a kind of relatively smaller proportion of patients. And this being highlighted here with patients with onset attacks, depending on the location, and showing how the recovery can vary with especially patients with longitudinally extensive transverse myelitis, as shown here, often experiencing residual symptomatology. Now, prevention of attack is clearly the best way to prevent disability in these diseases, since if an attack occurs, by definition, there is some degree of damage occurring, some degree of inflammation. Especially in aquaporin 4-HG seropositive NMOSD, we want to be make sure that patients who are diagnosed with this condition are on disease-modifying therapy, which is generally recommended to continue indefinitely, since these patients are perceived to be at lifelong risk for relapse. Of course, we can't prevent the first attack, though, and so we still will need to treat that attack aggressively. And again, despite our best efforts, relapses may still occur even with use of optimal disease-modifying therapy in NMOSD and MOGAD. One other thing to bear in mind is that in MOGAD, people with a first attack may often be observed without maintenance therapy. Since relapses may never occur, this is termed quote-unquote monophasic disease, or may be delayed with prolonged periods of intra-attack remission. And so these patients may be observed without being on disease-modifying therapy. So now we're going to move on and discuss, okay, we have a patient who did relapse, unfortunately, either the first attack or experienced a relapse subsequently, maybe despite the use of disease-modifying therapy or because they were not on disease-modifying therapy. What do we now do? And I would say the cornerstone of treatment really is high-dose corticosteroids. So high-dose corticosteroids, we recommend be used first line in all patients with NMOSD or MOGAD relapses. The advantages are, first of all, that they're accessible in most settings. They're very easy to initiate quickly. And notably, especially MOGAD relapses can be very exquisitely steroid responsive. We've seen patients with rapid resolution within a few hours or after initiation of corticosteroids having a near complete resolution of symptoms. The usual dosing regimen is intravenous methylprednisolone, 1,000 milligrams daily for 5 consecutive days, although that can range from 3 to 7, and this can depend on provider preference as well as the severity of the attack and the course. Notably, bioequivalent doses of oral corticosteroids, such as prednisone, 1,250 milligrams, can be considered for, especially for mild attacks that are being treated in the outpatient setting, since this way, no intravenous catheter peripheral IV would need to be placed in order to administer the medication. So there's a convenience factor there. For children, the dose is typically going to be weight-based at 30 milligrams per kilogram up to a maximum of 1,000 milligrams daily. And importantly, our experience, and this is corroborated by studies, have reported that rapid or short time to initiation of corticosteroids is generally associated with better outcomes. So while again, we sometimes see these patients in a delayed manner, unfortunately, due to late presentations to the emergency room or due to sometimes misdiagnosis. If the diagnosis is made early, we should be looking to initiate corticosteroids as early as possible, given these data. Now, in terms of how to approach tapering after an attack, this is a somewhat controversial topic, especially for MOG antibody disease, and practice can vary quite a bit. I'm going to kind of give my 2 cents here, my personal approach. In NMOSD, after completion of high-dose corticosteroids, I'd say that most experts would recommend oral prednisone. I typically will start at 1 milligram per kilogram daily, so up to 60 milligrams maximum dose, and then followed by a tapering of 10 milligrams of the daily dose per week until the patient reaches a dose of 20 milligrams. And then, given that NMOSD attacks can be quite severe, result in permanent disability, and patients are considered to be at high risk for relapse if they're not on treatment, I generally recommend continuing at least some prednisone until the patient is initiated on disease-modifying therapy. So this is kind of like a bridge over to that new therapy, either because they're being started de novo on a treatment, reinitiated after discontinuation, or being switched to a different one because of the fact that they sustained a relapse. Then the subsequent taper in order to take patients off corticosteroids, and my practice varies based on the selection of the disease-modifying therapy and when we think the onset of action is fully achieved. So with B-cell depleting therapies and anti-interleukin-6 receptor therapies or oral immunosuppressants, we generally think of them as taking a longer time potentially to take effect. And so in those situations, my tapers will typically be between kind of 3 and 6 months, or some may even do longer in some countries. And with complement component 5, C5 inhibitors, which seem to have a more rapid onset, at least of their action biologically, I typically will taper steroids over a period of 1 month. In MOGAD, which is, again, as I mentioned, a little bit more controversial, after completion of high-dose corticosteroids, I typically will do a taper that will vary between 8 and 16 weeks. There is some literature suggesting that longer tapers may be associated with a lower risk of early relapse, but some studies have not necessarily corroborated this. And I think we're going to have to wait for especially data from ongoing randomized controlled trials in order to better inform. But until then, my personal approach has been to utilize these kind of 8 to 16 week tapers, depending on a variety of factors. And I think that this is important to bear in mind that all of these treatments are rules of thumb and general recommendation, and then they need to be individually tailored based on the patient's specific profile. And this includes taking into account things like risk factors for side effects. So if a patient is, for example, a known diabetic, we know that steroids can exacerbate that condition, cause significant hyperglycemia. Steroids are associated with osteoporosis and osteopenia. So in patients who have those conditions pre-existing, you may not want to continue steroids for as long a period of time or even defer them completely. Patients are having issues tolerating them due to insomnia, behavioral side effects. Sometimes patients can even develop steroid-induced psychosis. These are all things that need to be taken into account, as well as the disease phenotype. So sometimes MOGAD patients, for example, may have a quote-unquote cryon phenotype, which is and be highly steroid dependent. And so in these cases, you may do a longer steroid taper, for example. Now, moving on, aside from steroids, the next approach that we will discuss is plasma exchange. So plasma exchange involves essentially running the blood of an individual through a machine that typically through use of centrifugation or other methods separates the blood, the plasma from the blood, removes the plasma, replaces it with replacement fluid that typically includes human albumin, or though sometimes other things like fresh frozen plasma can be used as replacement fluids, especially if there's a coagulopathy and we want to replace clotting factors. And the goal of this is to remove the plasma components from the blood, which includes especially antibodies, immune complexes, and cytokines. I'd say that the highest kind of molecule of interest here is antibodies, specifically in MOGAD and NMOSD, where we know that those antibodies are pathogenic. And then this leads to redistribution of antibodies from the extravascular space and a variety of downstream immunomodulatory changes. Now, in terms of practically how plasma exchange works, you need to have venous access with either two large bore peripheral IVs, so one for the blood to flow out of and one for the blood to be, and together with a replacement fluid to go back into the patient, or a dual lumen plex catheter that's inserted into a large central vein. Typically, plasma exchange is performed as 5 to 7 sessions over 10 to 14 days, typically every other day, although some institutions may employ consecutive day approaches to plasma exchange. And what happens is with each session, 1 to 1.5 plasma volumes are removed from the body per session. And these typically take a few hours to be done. Plasma exchange is generally safe, but as with any procedure, there are potential risks. And these include mainly central line related complications. So this can include bleeding, infection, something called pneumothorax, where air can enter the chest and compress the lung. Bleeding, because plex does remove clotting factors from the blood. Those are contained within the plasma that can lead to increased risk of bleeding. Low blood pressure, electrolyte changes and imbalances, cramping from low calcium in the blood due to the anticoagulants that are used, and sometimes hypersensitivity reactions due to additives that are contained within the replacement fluid and within the machine itself to prevent clotting. Importantly and critically, plasma exchange does not remove corticosteroids from the bloodstream, since corticosteroids actually go and stick on proteins within the blood, and protein is not removed from the blood when we do plasma exchange. And also corticosteroids rapidly go to the tissues and then cannot be removed by plex. This is important because that means that we can use high-dose corticosteroids and plex concurrently together without worrying that the plex may remove the steroids from our patient and hamper their therapeutic effects. Importantly, though, plasma exchange will remove circulating monoclonal antibodies or IVIG. And this is very important to consider in patients who are on disease-modifying therapies, many of which are monoclonal antibodies, because by instituting plasma exchange, we may remove those from the blood and decrease their effectiveness. So when do we use plasma exchange? So Plex has been reported to overall be very effective as a treatment in MOGAD and NMOSD attacks in multiple studies that are retrospective. There's a very strong biological rationale since these are autoantibody mediated diseases, and we are removing the culprit from the bloodstream by doing plasma exchange. Earlier time to initiation of Plex appears to be associated with better outcomes. This is kind of a similar principle to what we were discussing with high-dose corticosteroids, that earlier institution of the treatment may result in better recovery, since we're minimizing by doing that nerve and other cells being damaged within the central nervous system. In terms of the approach to instituting Plex, there are two main treatment paradigms, and again, there can be hybrid paradigms as well, as I'm going to discuss, but the traditional quote unquote rescue plex approach involves starting with high-dose corticosteroids and then adding or escalating to plasma exchange when severe attacks fail to improve or there is persistent disability again after high-dose corticosteroids. The other side of the spectrum would be an early plex approach where we initiate plex as soon as possible concurrently with high-dose corticosteroids in any case of known or suspected NMOSD or MOGAD. Now, my approach is kind of a hybrid approach between these, especially in the absence of randomized controlled trials and as we are accumulating more evidence about this. But I think that based on the existing literature and our clinical experience for severe attacks and or recurrent attacks in a previously affected location in NMOSD, plex initiation early and concurrently with high-dose corticosteroids is recommended. And what I mean by a previously affected location, often patients who are coming in with a relapse may have had a previous attack. Let's say, for example, somebody had a right optic neuritis and they have not fully recovered vision in that eye. A second hit to that same optic nerve may result in even more permanent disability since the reserve of that eye has been impacted quite a bit. And so in such cases, I think that there's a clear justification for starting plex early and also for, again, severe attacks, let's say in the spinal cord, for example, there's a very strong rationale to just initiate plex very early concurrently with a high-dose corticosteroid rather than wait and see if the patient responds to steroids. In MOGAD, as we discussed, recovery from attacks can be quite good, and recovery with steroids alone can be quite good, with patients responding very rapidly and dramatically to steroids. However, plex can still be considered, especially for attacks that do not respond well to high-dose corticosteroids. And I would consider early plex for severe attacks, especially spinal cord involvement, where, as we discussed previously, often patients may experience residual dysfunction, especially bowel, bladder, or sexual dysfunction. And so there is a rationale there to start plex early on rather than wait and see if they improve with steroids, since there is a potential for early plex to limit the damage and the downstream disability from that event. And similar to what I discussed previously with NMO, I would consider early plex very strongly in patients where the attack is involving a previously affected location, especially if there's residual disability from that prior attack. Now, another approach for treatment of attacks is the use of intravenous immune globulin. Immune globulin is essentially a formulation that involves pooling immunoglobulin derived from plasma donations from thousands of donors and infusing it in high doses in individuals with autoimmune diseases. There are multiple biological mechanisms by which this has an anti-inflammatory effect. Now, it's typically administered as a 2 gram per kilogram load over split over 3 to 5 days. The evidence for effectiveness as a maintenance therapy or as an acute therapy, I would say, in NMOSD attacks is rather limited. But in MOG antibody disease, IVIG appears to be quite effective for relapse prevention, and this is consistently shown across multiple studies, but also may be effective as a treatment acutely in MOGAD, although as an acute treatment, experience is more limited. Furthermore, given the fact that IVIG stays in the body for quite some time and has a long half-life, it can be expected to continue exerting immunomodulatory effects and protecting against relapse in the early post-relapse period. And this is, I think, an important consideration, especially in MOGAD, where there's this concern about rebound as the steroids are being tapered. Now, in terms of my recommendations and approach for the use of IVIG for treatment of acute attacks, I'd say for NMOSD, plex is preferred if available. And so IVIG could be considered if there's no access to plex. Can also consider some biologics that we will be discussing towards the end of the lecture. But I would say that plasma exchange has a much stronger evidence basis for treatment of acute attacks in NMOSD. But again, if there's an availability, accessibility issue, IVIG could be considered if that's not a possibility. In MOGAD, I'd say that IVIG or Plex can be considered in cases with persistent symptoms despite steroids, and this can depend based on venous access issues, tolerability, risk factors for complication, and accessibility to these treatments. For severe attacks, so in general, I would prefer Plex, and sometimes we can even consider kind of using these in tandem, so loading with IVIG after completing Plex. So this instance, the patient would be treated with high-dose corticosteroids, Plex, potentially even concurrently, and then followed with IVIG. And then the IVIG has the advantage that it can be continued as a maintenance therapy in MOGAD, given evidence that it is quite effective at relapse prevention. Now, in terms of other acute treatments, there is emerging evidence that C5 inhibition can be used in acute NMOSD attacks, and this has a very strong biological rationale. So complement activation is a key contributor to injury in lesions and acute attacks in NMOSD. I'd say the role in MOGAD is a little bit more controversial and less well defined. C5 complement inhibitors have been shown to be highly effective for relapse prevention in aquaporin 4 IgG seropositive NMO. And so there's a strong biological rationale that they could potentially be effective in acute treatment of NMOSD attacks, not just as a maintenance, although the evidence is mainly restricted to small case series, the largest being published recently, including 33 people with aquaporin 4 IgG seropositive NMO who were treated acutely with C5 inhibitors. All patients stabilized, and a significant proportion experienced at least moderate or even good recovery. And so I'd say that these data are quite encouraging and do kind of suggest that they can at least be considered in the acute phase, especially in patients who have not responded well to steroids and Plex. So based on that, I would definitely consider them acutely. I think that the situations in which they should be considered are in acute NMOSD attacks, again, aquaporin 4 IgG seropositive, in which cases we are potentially planning to use them as a maintenance therapy after the index attack, but also in patients who have persistent significant disability after high-dose steroids and plasma exchange, or if we are unable to do plasma exchange, but have access to C5 inhibitors. One important consideration if we do use C5 inhibitors in this setting is that because of their mechanism of action, they are associated with an increased risk of infection with encapsulated bacteria. Especially concern is for meningococcal infection. And the recommendation is that patients be vaccinated at least 2 weeks prior to initiation of such a treatment. In instances where they're being initiated emergently, we would recommend use of prophylactic antibiotics since there's not enough time to administer those required vaccinations. Moving on, we're going to discuss anti-interleukin-6 receptor treatments in acute NMOSD and MOGAD attacks. Interleukin-6 is an inflammatory signaling molecule, a cytokine that plays a key role in the pathophysiology of NMOSD and MOGAD. Notably, cerebrospinal fluid IL-6 levels are elevated significantly in NMOSD and MOGAD during attacks. Therapies targeting the interleukin-6 receptor, tocilizumab and satralizumab, have been reported in clinical trials to be effective for relapse prevention in NMOSD, as well as in MOG antibody disease, specifically satralizumab, but there is also evidence for tocilizumab from retrospective observational studies. In terms of the use acutely, this is, again, mainly restricted to case reports and case series, but there are very compelling reports of acute use with very dramatic response, especially in pediatric MOGAD patients with malignant cerebral edema and impending brain herniation with kind of rapid improvement after initiation of tocilizumab in patients who were not improving with high-dose corticosteroids. In terms of the dosing schema, an example of acute dosing would be tocilizumab intravenously being administered at an 8 milligram per kilogram dose, although this can vary from study to study. And so I do think that this is another consideration, especially if patients are exhibiting persistent significant disability after high-dose corticosteroids and plasma exchange, or we are unable to do plasma exchange. Cases of pediatric MOGAD with severe cerebral edema and even impending herniation, I think that there you could definitely consider using it emergently, and there's studies showing that potentially that could avoid things like a decompressive craniectomy. And as also if we are planning to use an anti-IL-6 receptor treatment as a maintenance therapy after the index attack that we are treating. And so bringing this all together, we have here a kind of pocket card approach to treating NMOSD or MOGAD attacks. So we have a patient presenting with new or worsening neurological symptoms concerning for an NMOSD or MOGAD attack. Firstly, we definitely want to confirm that this is indeed a relapse rather than something else or an initial attack based on history, exam, and paraclinical evaluation as indicated using tools such as MRI. Blood-based biomarkers can be useful, but I do think it's important to bear in mind that time is brain. This is an approach in stroke that I think we can think of when we're thinking of NMO and MOGAD. So time is spinal cord, time is optic nerve. So we should not necessarily delay treatments just to be 100% sure that it is a relapse. If the history and exam do support that this is an attack, often it's best to start treatment as the evaluation and workup is ongoing concurrently. So typically we will be using initially high-dose corticosteroids, which can be started very quickly with IV methylprednisolone or an oral bioequivalent. And then I show here how the approach can potentially differ depending on what the suspected or known underlying disease is. So if it's NMOSD, we typically will consider adding PLEX in severe attacks, attacks in previously affected anatomical locations with residual disability, if patients have residual disability after high-dose steroids, and then can consider C5 inhibitor therapy or anti-IL-6 receptor therapy if there's persistent disability despite steroids and PLEX, or if, say, PLEX is not available. Also, IVIG can be considered if PLEX is not available potentially as well. And then we'll typically bridge to long-term disease-modifying therapy with an oral corticosteroid taper and overlap the steroids with that DMT until the DMT takes its full biological effect. On the other hand, in MOGAD, we typically would consider adding PLEX or IVIG or even using them in tandem. So that would be PLEX followed by IVIG in severe attacks, especially spinal cord involvement, which can often result in residual disability, attacks in previously affected anatomical locations, especially if there's residual disability from those attacks, and in cases where there's disability despite high-dose steroids. Also, just want to make a note again of the use of anti-IL-6 receptor treatments urgently in cases with malignant cerebral edema. Following this, we'll typically taper corticosteroids. Again, the duration can vary from provider to provider and based on individual patient characteristics, but typically will be 2 weeks or more. And then we should consider initiation of disease-modifying therapy in patients who have relapsing disease, so 2 or more attacks, or can be considered also in patients with a severe first attack with incomplete recovery.
Thank you, Elias, for that wonderful overview, very thorough, of all of the different treatment options for acute relapses in both NMOSD and MOGAD. We have a few minutes for questions and answers, so let's begin with this one. In patients who have severe and refractory attacks, do you find any utility in simply beginning by repeating a course of high-dose corticosteroids?
Yeah, that's a great question. And that's definitely something that I've seen used in clinical practice and I've actually done myself. I do think that there is a role for that to consider, although my personal thinking about this has evolved over time. So now that we have some evidence for the use of biological therapies, I feel like that is something that is potentially more compelling to me rather than repeating something that may have not worked already. And so typically my approach has evolved to if a patient has not improved with steroids and PLEX, I'll still leave them on oral corticosteroids because, as I said, I taper most patients, but I typically will not repeat high-dose corticosteroids, but escalate to use of a biological, depending again on the condition. That could be an anti-interleukin-6 receptor blocker or a complement 5 inhibitor. So that would kind of be my approach.
Yeah, very good and makes sense. let's say for patients who have had a severe attack and they've already received both steroids and an initial course of plasma exchange and haven't responded satisfactorily, how would you weigh a decision to use, as you were just referring to, some of the biologic therapies, either the complement inhibitors like eculizumab or ravulizumab, versus more plasma exchange or perhaps an interleukin-6 receptor inhibitor? And this is specifically in NMOSD.
Yeah, that's a great question. I think that overall, my interpretation of the literature has been that beyond 5 and especially 7 plex cycles, the benefit starts to decrease quite a bit since we've kind of exchanged at that point the multiple plasma volumes. And so the autoantibody remaining in the bloodstream is quite low. And so I think that at that point, the maximum number of plasma exchange sessions that I generally have recommended in such situations is 7. And then if a patient has not responded at that point, I'll typically proceed to monoclonal antibodies in that situation. Now, one thing that I didn't mention, which could be considered as well, and I know that I've heard from colleagues that they've been able to do this, although I think that there's an accessibility and cost issue to bear in mind, is that, for example, C5 inhibitors or anti-interleukin-6 receptors could be dosed concurrently with plasma exchange. So giving kind of supplemental doses after a plasma exchange session, recognizing that the next session you do is going to remove it. However, I would say that I'm not sure about the availability of doing that given the cost of the medications, but if that's available, that can also be considered potentially as well. Then in terms of after completion of those 5 or 7 sessions, I'll typically extend it out to 7 sessions of plasma exchange. At that point, I feel like additional plasma exchange is unlikely to be beneficial. And then we will consider addition of the C5 inhibitor anti-interleukin-6 blocker. And then I think that at that point, it really there is, I would say, equipoise on which approach would be ideal. To some extent, for me, it may depend on a conversation I've already had about what kind of maintenance therapy we're going to be using moving forward. So if our plan is to continue with C5 inhibition as a long-term maintenance therapy strategy, then I think it makes sense to use that to treat the acute attack as well. If our plan is to use anti-interleukin-6 receptor blockade as a long-term maintenance therapy, I would feel inclined to use that as the acute therapy and then continue it as a maintenance therapy moving forward.
Yeah, excellent thoughts. And it's exciting to have such a good understanding of the biology still emerging, but of these diseases that and some available therapies that we might be able to extrapolate to acute therapy. On that note, if we go over to MOGAD for a moment, what are your thoughts on the potential for complement inhibition as an acute therapy for MOGAD relapse?
Yeah, I think that this is a really interesting topic, and it's a hot topic in the field of MOG antibody disease. So there's more evidence emerging that complement also plays a role in MOG antibody disease. This is derived from neuropathologic studies, so looking at lesions from people with MOG antibody disease. And while it's definitely not as prominent as it is in aquaporin 4 IgG seropositive NMO, there is evidence of complement deposition within MOGAD lesions. There's evidence that MOG antibodies can activate complement, and that can contribute to the downstream injury that occurs in the disease. And there's also studies looking at cerebrospinal fluid and looking at complement components there, which do show signatures of complement activation in patients with MOG antibody disease in the context of acute attacks. I would say, though, that the evidence is not as strong as it is in NMO for treating acute relapses. And also, there is no evidence for use of complement inhibition as maintenance therapies in MOG antibody disease in terms of trials. And so I would be hesitant to recommend it right now, but I definitely think that it's an area that we should pursue studies, including clinical trials, and that can definitely help us and inform our understanding of how to use them for MOGAD treatments potentially.
Yes, very good. Finally, some patients have quite devastating attacks in these diseases. This could be any of NMOSD, MOGAD, or even multiple sclerosis in uncommon situations. And sometimes when we feel like we're nearly exhausting our options for treatment, and especially if you reference some of the access issues that might be relevant for using some of the biologic therapies. Often people think about some of the older treatments, general immune suppressants that have historically been used, say high-dose cyclophosphamide. Is that a reasonable option at this point?
Yeah, it's a great question. And I think that, again, as you said, historically, it's an approach that's been used not only for MOGAD and NMO, but maybe for undifferentiated CNS inflammatory diseases or severe attacks of MS, with agents such as cyclophosphamide or say things like high-dose methotrexate with leucovorin rescue has been proposed for severe CNS inflammatory attacks. I generally am hesitant, I would say, to use those unless I've exhausted other options, given the high risks associated with these treatments, the high risk for potential toxicity. But I do think that these can still be considered as a last resort if patients have been treated optimally with all the treatments that we've discussed, including steroids, plasma exchange, and we've attempted to use biologics, or maybe we don't have access to them, and we have patients who still are exhibiting worsening. And I would say especially MRI can be quite helpful if we're seeing active inflammation. I think that then they can be considered, but I would be hesitant because I think that there's potential toxicities, and there is even potentially impairment of remyelination and recovery that can occur following attacks by use of chemotherapeutic agents. But I do think that it should be considered. But I just want to say one caveat there is that also we do see patients who seem to not be improving. And the disease's natural history, it can take time to improve. And often as clinicians, we're looking for that instant gratification that we give a treatment and we see the patient get better all of a sudden and very quickly. And it can be quite frustrating when we don't see that happening. But I also think that sometimes do no harm is kind of an important axiom in medicine. And so I think that if we were to do something like that, I would want to make sure that we're clearly seeing that not only are things not improving necessarily, but we're seeing that there's clear evidence of ongoing disease activity despite our intervention, such as progression of the lesion at MRI, the patient actually worsening. I think those are situations which I would use it. I would be hesitant if, let's say, the lesion is looking better, but the clinical recovery can sometimes lag. I would want to make sure that we're not over treating the patient and actually causing unintentional harm at that point.
Yeah, excellent. Really complex situations sometimes when these devastating attacks occur. I'd like to thank you, Elias, on behalf of the Patient Health Alliance and all of our viewers today for your willingness to share your experience and expertise in this complicated topic. And I think you did a wonderful job of clarifying the options and also what we need to do to move forward.
Yeah, thank you so much for being here. It was a pleasure to participate.
For those of you viewing today, thank you for your participation, and we hope that this course was helpful. As mentioned earlier, the NMO Master Class has a number of events. We have a link and a QR code on the screen here where you can access on the internet a list of educational events, featured speakers, and presentations and media, all related to the NMOSD Master Class. Finally, the NMOSD Master Class is sponsored by an educational grant from Alexion, AstraZeneca Rare Disease, and we're grateful to them for their support. Once again, thank all of you for participating and wish you a good day.